I think what I'm going to do is I'm going to split single and double contrast BEs into separate lessons and recordings. And I'm going to do that because one single recording might be a little bit long. One thing I'm not going to do is repeat the positions for single contrast in double contrast. So in my experience, my personal experience, professional experience, the difference between single contrast and double are that the double contrast includes all of the projections of a single contrast but has more in addition to. So I'm going to cover all the positions for single contrast, close that recording, do another one for double contrast, not include the projections for single contrast, just keep the video short, but I am going to include the pathologies on the double contrast on the second recording. So you might hear a little bit of background noise. I didn't notice until last time I was editing a video. My fire in the fireplace, the popping of fire in the fireplace, the computer microphone picks it up. So just ignore that. So why might we do a diagnostic enema? The indications would be change in bowel habit, history of diverticulosis. The diverticulosis may become inflamed and become diverticulitis. History of Crohn's disease. A similar condition in the large intestine as a small intestine history of Crohn's disease would be ulcerative colitis. If the patient's passing blood, it could be an indication the patient has ulcerative colitis. We've got clinical indications for bowel obstruction, pain and tenderness, reflex tenderness with elevated white blood cell count could point to something like an appendicitis. Appendicitis is not necessarily an indication for a barium enema, but we sometimes, I've worked in a hospital where it was part of the protocol to do a gastrograph enema or a iodinated contrast enema for appendicitis. So single contrast BE, we've already been through all the setup, so I'm going to recycle one of the slides or some of the slides from the setup just to kind of review some of that stuff, but I'm not going to go all the way back through all that. So this is assuming that you've already completed the setup and you're ready to go. You've gone and you've spoken with the radiologist, you've talked about the patient's history and what's going on with the patient. So now then you are in the room with the patient, the radiologist or the PA or the RA show up. And I'm just going to say radiologist and understand that when I say radiologist, I'm including anybody who may be performing the job of the radiologist, in this case running a fluoroscopy. So your part in the BE, be it single contrast, double contrast, certainly to keep the patient comfortable, keep the patient covered, make sure the patient doesn't become uncovered, and also your radiologist may have you start and stop the barium. So what you're going to do is you're going to open the clip, release the hemostats if you chose to use hemostats, and allow the barium to flow into the patient. So the flow of the barium may stop and start several times within the procedure, so the radiologist may put some barium into the patient, have them roll into different positions. As the barium moves through the colon, the doctor may ask you to turn the barium back on. So usually in my experience, that's barium on, barium off would be your indication to either open or close that tubing. So they're going to be looking on the screen as they're fluoroing the patient, as they're filling the patient with barium. So the radiologist is going to tell the patient what position to move into, and at this point what you're going to do is you're going to elevate the sheet just to make sure that the sheet doesn't get wrapped around the patient and then uncover the patient, because a hospital gown does not do well at keeping the patient covered. So one thing that you will want to do, I combined two slides to make this one. You notice this when you've got would be the bulb to either inflate the retention cuff, which this enema tip does not have one, or it would be to introduce air, either one. So what you don't see though there in that picture unless it's right there, is the clip to turn on and off the barium. So what you're going to want to do is you're going to want to bleed all the air out of that, but you're going to want to move this clip further up the tubing so it's a little bit more convenient. It's a little uncomfortable, not really uncomfortably physically, but in a violation of my space kind of way, to get up under the patient's sheets to try to turn the barium on and barium off, and it's just not convenient, it's not ergonomic. So move it down here somewhere so that you can get to it whenever you need to. So the radiologist is going to roll the patient around in different positions to take spot radiographs as needed. They'll probably go ahead and get good images of the flexures. They may get images of the ascending, descending colon, and sigmoid colon as well. So if they don't see what they need to see during fluoroscopy, or they want another look at something, they may request overheads. So be familiar with your doctor's protocols and make sure that you follow those protocols, but also listen as the doctor leaves the room so that you know what it is that what they want. Sometimes they'll ask for a limited series. So what you're going to do is you're going to leave the retention balloon inflated, and you'll perform your exam, and that's what will follow here. So after you get done with all your images, what you're going to do is you're going to take the patient to the restroom and have the patient expel as much of the barium as possible, and then you're going to come back and you're going to take another image of the patient, and that's what we refer to as a post-evac image. All right, so we've got a number of different views that we're going to do. You can do AP or PA. In my personal experience, for single contrast, we've always done AP. I've never worked in a hospital where PA was routine, but we're going to do AP obliques. Axial is an AP axial, and we're going to do lateral of some sort. So we're going to do an AP, two obliques, an axial, a lateral, and then we're going to do the post-evac images. So what I recommend that you do is get in the habit of writing down your projections in a logical order and only have the patient rotate one time, so that increases your efficiency, makes you look like you know what you're doing, much better than having the patient roll over and over again. It's more efficient, it's more comfortable for the patient, it gets you through the examination quicker. So what I would recommend that you do is do your AP. You can do your AP axial. Since you haven't changed the patient's position, body position, they're still supine. Go ahead and do your AP axial. And then what you can do is rock the patient up onto their right hand, or not completely on the right hand side, but rock them up into an RPO position, and then an LPO position, and then all the way up for a lateral. Now sometimes your hospital protocols will call for a lateral cross table with the enema tip removed, and that complicates things a little bit. It puts the patient into a ventral decubitus position so that you're shooting a cross table lateral, and it's a little bit more challenging, but if that's hospital protocol, in the last video I mentioned being able to visualize the retrorectal space, and that's where you are here. So also then you would take the patient to the restroom, let them evacuate their bowels, make sure that you explain to them that they're going to make a little bit of noise in there, and everybody understands that, and not to be embarrassed by it. Then you would bring the patient back to the table and shoot your post-evacuation. So now we're going to talk about each one of these individually. I am going to talk about an AP axial oblique, which is a local protocol that you won't find anywhere else, but I will cover that as well. It's just like the AP axial, it's just with the patient in an LPO position. So you can shoot PA, but again, I'm going to explain this in context of AP. When we get to double contrast, we're going to include a PA as a routine. So in double contrast, we're going to shoot AP and PA. But in case your local protocol is for on-solid single contrast barium enemas, you shoot PA. I'm going to go ahead and leave that in here. So the patient, if you're shooting AP, is going to be supine. Your mid-sagittal plane is going to be centered to the midline of the image receptor. You want to make sure that you don't have any rotation, And that's by making sure the patient's shoulders aren't rotated and the distance from the ASIS to the tabletop is equidistant. And then you're going to center your image receptor at the iliac crest, and then certainly your central ray to the center of that. Now your collimated field should be 14 by 17 on most patients. If you have a patient who's thin, you can go a little bit less than that, but if you have an adult, you're pretty much going to use that full 17 inches. If you're working off of an image receptor that's 14 by 17 and you have a hypersthenic patient, then you might want to do something a little bit different for certain views. Each one of these views are going to show you something specific. So in the AP, what we're going to see is the entire colon. So you want to be able to see from the flexures all the way down to the rectum and the anus. So if you have a hypersthenic patient that won't fit on the crosswise dimensions of 14 inches, then if you're using a DR image receptor, certainly you can open up your collimator a little bit wider to try to include all that. But if you have a patient, or if you have image receptors that are truly 14 by 17, then what you may need to do is take two images. So the first image you would position kind of like a pelvis. You would take the image receptor and you would put it in crosswise. So the long axis of the image receptor is going across the patient's body, positioned like a pelvis with the top of the image receptor at the iliac crest, and your collimated field would be 14 by 17 with a 14 dimension being lengthwise on the patient's body and the 17-inch dimension going across the patient's body. That would be one view. The second view, you would put the bottom of the image receptor just below the iliac crest so that you have a little bit of overlap between the two images, and in your hypersthenic patients you should be able to get all of their colon on those two views. But again, if you're using a DR image receptor, you shouldn't really have to do that. You should have enough room that you can open up your collimators and get the whole thing. So that's what it looks like. You don't want any kind of rotation, central ray to the level of iliac crest, and collimate down to the skin level. Probably collimate down a little bit more on that. So what we're going to be looking for is that proper collimation. We don't want any kind of rotation, so we're going to look at our vertebra to determine rotation. We want the vertebra in the center of the image receptor. If you have a patient with scoliosis, then your mileage may vary a little bit, but barring that, you want the vertebral column in the center. So you want the entire colon. Again, if you have somebody who's very tall or hypersthenic, then you may need multiple views to get the flexures. So your exposure technique, your minimum KVP is going to be 110 KVP for barium work. If you're using iodinated contrast, then you can drop that KVP down to about 90. But if you use 90 KVP for barium, then what you're going to have is a very high mass value, as that barium absorbs a tremendous number of x-rays. So this is what we should see. We've got the vertebra in the middle. You should have been through vertebral positioning by now, so and KUBs as well. So what you should know is that is the spinous process, and it's right in the middle of the vertebra. We don't have any kind of rotation there. That's a good image. It shows the entire colon, everything that we want to include. It's a little dark, though. I would say that I would question if they used 110 kVp or above. So the AP axial, again, patient's still supine, but what we're going to do this time is we're going to position the image receptor 2 inches above the iliac crest. So we're going to angle cephalic. So if you angle at the iliac crest, you're going to project the image towards the top of the image receptor or off of the image receptor. We're not interested in seeing the entire colon in this case. What we're looking for is the sigmoid colon. Now it's important to understand that all of the views that we're going to do for a single contrast exam, we're going to do for a double contrast exam, but we're also going to do the exact opposite as well. So anything that you shoot AP, you can shoot PA, and what we're going to see though is with the air contrast, we're going to have to determine where the air is going to be and also where the barium is going to be. So we've got this AP axial. Later we're going to do a PA axial, and the centering is a little different for that. So our angulation is going to be 30 to 40 degrees cephalic. It's going to enter at the mid-sagittal plane to the inferior margin of the symphysis pubis. I tell my students never to palpate the symphysis pubis. If your instructor is a symphysis pubis palpator, then certainly follow their instructions. I just personally see too much of a chance for some sort of litigation in that, so I tell my students not to do that. What you can do, though, is to use other body landmarks to determine where the symphysis pubis is. Greater trochanter should be at the level of the symphysis pubis, so you can base that on the hip. Also, the distance between the ASIS and the symphysis pubis is about 4 inches. So those would be my recommendations rather than palpating the symphysis pubis. And the textbook calls for a 14 by 17 inch collimated field, and I think that's a little bit excessive. You could probably get by with 12 by 14. You collimate in a little bit smaller than that, remembering that primarily what we're looking for is the sigmoid colon. So we're going to look for proper collimation. We're looking at the rectosigmoid area. And what the angulation should do is give us less superimposition than what we had in the AP. So the central ray angulation, because the sigmoid colon goes from posterior to a little bit more anterior and inferior, you've got a significant curl to it there. And the purpose for the angulation is to try to straighten that out a little bit. So what you're not looking for is transverse colon flexures, and that's why I say that you can collimate down a little bit more. You don't have to have as much collimated field as what you need on all of the other views, with the exception of the lateral rectum. All right, so it looks like that. So we've got 30 to 40 degrees cephalic angulation. Again, your ASIS is right about here. So in this positioning, we've got our central ray just cephalic to, or I'm sorry, yeah, well, just proximal to, cephalic to the symphysis pubis. And that's what it should look like. So, and really, I would have included a little bit more on this. But you notice that even with the central ray angulation, you just have a difficult time getting the loop of the sigmoid colon without any kind of superimposition at all. Now, local protocol is to do an LPO sigmoid. The positioning would be identical. The only difference would be, again, that you rotate the patient up into an LPO. So that's local protocol. Again, I've not seen that anywhere else aside from my local hospitals. And I've worked in 2 or 3 other hospitals, never in the region, and never seen anybody else do them. So AP, this is actually air contrast. I'll recycle this in the air contrast lecture portion. You can tell it's air contrast because the dark areas within the colon represents air. So again, sigmoid colon, that's what we're looking at. So now we're just going to talk about the AP obliques. So we're going to do bilateral obliques. They're going to be 35 to 45 degrees, LPO and RPO. You're going to do both of them. I know that says or, but in context, it's saying one at a time. So LPO or RPO, you're going to do both. So what we're going to see then is different things on those views. Now I'm going to use this charger cable to hopefully show you what it is that we're looking for on the obliques. And if you watch the anatomy video, you know that the colon doesn't just come up the ascending side, make a turn to go from the hepatic flexure across to the splenic flexure and then down into the descending colon. It makes 2 turns really. It turns from the hepatic flexure to go across the patient's abdomen, yes, but it also changes from posterior to anterior. So your transverse colon is more anterior than the rest of your colon. until at least we get to the sigmoid or rectum and anus. So what we've got then is a double curve, and with the patient laying flat on their back, if you notice on both of these flexures, we've got superimposition that we have to deal with. So I want you to watch what happens to these curves as I rotate this up. So what I'm going to do is I'm going to pull the hepatic flexure, the right-hand side, back towards me while I extend the splenic flexure. I guess I could put it further up in the air to be a better representation. I'm going to push it away from me, so that would put this mock patient, so to speak, into an RPO position. And if you notice, what we get then is the splenic flexure becomes more open. So the side that's elevated is more open, all right? So what we though get is more superimposition on the side that's closest to the image receptor. So this one's closest to my head. This one I got to reach for to get to it, and I can see through this splenic flexure. So the RPO position opens up the side that's furthest away from the image receptor. Some people will say the upside. So the side that's furthest away from the image receptor, the RPO shows us the splenic flexure. If the RPO shows us the splenic flexure, then naturally the LPO is going to show us the hepatic flexure. So in those two views, we can see without superimposition as much as we can, patient's anatomy allowing, we can see those two flexures very well. So in both cases, we're going to oblique the patient 35 to 45 degrees into LPO or RPO. The LPO demonstrates the right colic flexure. The right colic flexure is also referred to as the hepatic flexure. And then we're going to rotate the patient into the RPO, and that's going to give us the left colic flexure, and that's also referred to as a splenic flexure. So our positioning, mid-sagittal plane, should be directly in the middle of the image receptor, and how we're going to do that is to position just anterior to the upside ASIS. So our sponge, you can put the patient on a sponge if you like, but if the patient can participate and they have the body strength, then you can have the patient rotate up just by putting their arm across their chest. If they're rotating towards the right hand side, then their left arm will go across the chest, and then you would also have the patient bend their left knee to roll them up into that RPO position, and then reverse that procedure for the LPO. This is where I need to pick up. So your central ray is going to enter the patient about 1 to 2 inches lateral to the midline on the elevated side at the level of the iliac crest. And again, your collimated field is going to be 14 by 17. Keep in mind that what we're doing this specifically for is the flexure. So even though it says to position at the iliac crest, use a little bit of discretion in your clinical positioning. And what you might want to do is intentionally off center, or not really off center, but elevate the positioning of your central ray so that you come in a little bit higher than that. It's better to misposition and make sure you get the flexures than to have to go back and reshoot those. So sometimes, especially your splenic flexure is going to be a little bit higher, and you may not be able to include it on the RPO. So you might want to off-center just a little bit, or rather center a little bit high. So your body positioning looks like this. Again, 35 to 40 degree oblique. And you're going to do both LPO and RPO. And your central ray is going to be about 1 inch lateral to the elevated side, mid-sagittal plane. So if you go just medial to the elevated side, ASIS, it should give you the same thing. It's a little less guesswork. And what they're going to look like is that. Again, your LPO is going to give you the right colic flexure, and also remember that the right colic flexure is going to also be referred to as the hepatic flexure, and then also your RPO then is going to show you your left colic flexure. And they, again, could have centered just a little bit higher to make sure that they get the very top of that splenic flexure there. So again, it looks like that. Your textbook may refer to this last position as a lateral large intestine. In fact, what we're going to be looking at is lateral rectum. So it's not as dramatic, and your field size should be much smaller, on a level of about 10 by 12 as opposed to 14 by 17. And there's a lot of different laterals that we can do. We can have the patient rotate up into a left lateral or right lateral position and shoot it kind of like what we would do a lateral L spine or L5S1 spot would probably be a little bit more accurate. But some of your hospital protocols may call for the patient to be either supine or prone, so they're laying down, and we utilize a cross-table lateral. Of those two, probably the more common that I've seen is with the patient laying prone with the enema tip removed, shooting cross-table lateral. And we're going to take a look at what that would look like on an air contrast enema here in just a minute. But what we're going to do is we're going to position the mid-coronal plane to the image receptor, and we're going to rotate the patient up into a true lateral position so that just like a lateral L spine, you would put the hips on top of each other, you put the knees on top of each other, flex the knees, just gives them a more stable base instead of laying there with their legs extended, and then put their feet on top of each other. Make sure the shoulders are superimposed as well. Your central ray, and your centering to your image receptor is going to be at the ASIS. Now, if the patient's prone, that's going to be a little bit more difficult to find the ASIS, so what you might have to do is have the patient rotate up into a slight RAO position so that you can find the ASIS to center your central ray and your image receptor. So all of that we just talked about. Your collimated field 10 by 12. The 10-inch dimension is crosswise across the patient's body from anterior to posterior, and 12 inches the length of the patient's body. So once you shoot your image, you want to look for proper collimation. Make sure that you did not shoot on that full 14 by 17 just for the rectosigmoid area. So you're just looking for a very small area. You don't need an entire image receptor. You want to look for rotation, so look for the humeral heads to be superimposed would be a good thing to look for. And keep in mind that we don't need to see the top of the colon in those flexures. So again, a 10 by 12 image receptor. And you want to make sure you get good penetration. So positioning wise, it looks something like that. And on your image, it looks something like that. So what you're seeing here, this dark area with that light area going through it, that is that retention cuff. So the enema tip is still in this particular patient, and it just looks like a regular lateral. And this would be an air contrast exam, and we'll take a look at that again whenever we look at air contrast exams. And this would be an air contrast with the patient in a ventral decubitus. So they're laying on their stomach, and you can see that air fluid levels, telltale sign that we're looking at cross-table lateral. You just don't get that air fluid level without the cross-table lateral. So increasingly, I've seen this become more of a routine, and what we're looking at here, or in a lot of cases, what we're looking at whenever we do a ventral decubitus is to do it with the enema tip out. So once we get all of that done, we get the patient up and we take them to the bathroom and we let them evacuate their bowels. And then we come back and we take one more image as a post-evac. Keep in mind, your body habitus may require you to either open your collimated field to the full size of your digital image receptor, or if you're using an image receptor that's 14 by 17, you might have to take two images crosswise in order to visualize everything. So, and again, your positioning there would be to position one like the pelvis. So the top of your image receptor would be at the iliac crest for that image, and then the second image, the bottom of your image receptor would be just below the iliac crest. so you make sure you have some overlap. Because of the divergence of the central ray, if you position both of them at the iliac crest, you're going to miss some anatomy. So you want a little bit of overlap. So that is solid column or single contrast BE. If you have any questions, just post them down in the comments. Like, subscribe, share. And next up, we're going to do air contrast BE.